आनंद जी।
जी, गुड इवनिंग।
गुड इवनिंग। डॉक्टर सक्सेना जुट गए हैं?
हेलो।
10 मिनट या सर हो गया, फिर शुरू करा। क्लास शुरू करा। डॉक्टर पुनीत सक्सेना इज हियर।
सर सर ज्वाइन कर रहे हैं
हाँ। हेलो।
सर।
हेलो।
जी सर, पुनीत सर 2 मिनट में ज्वाइन कर रहे हैं सर, आज बात हुई उनसे।
अच्छा, बात हो गई ना?
हाँ जी जी, 2 मिनट बोले, 2 मिनट में ज्वाइन कर रहे हैं।
एक बार फिर सर को बोलिए।
Good afternoon, everybody.
Good afternoon, sir.
Good afternoon. Can you hear me?
Yeah, you are audible. So
Dr. Sanjay,
we should start the class now.
apologies for a few minutes late, but there was a connectivity issue. So
No issue, sir. No issue, sir. So on behalf of ICP Dean Dr. Kamlesh Tiwari, I welcome all the participants in this class of diabetes. So without wasting time, may I request Dr. Puneet Saxena to kindly start the class?
all right, just give me a minute. I'll just put on
Sure,
my slides and so that.
Sure.
Sir, can you see my slides?
It is not in the presentation mode.
Okay, I'll do that. Now?
Yeah, you make it full. Yes, now it is okay.
All right, that's good. Thank you very much. So I welcome all the participants over here for the fourth class of this ICP short certificate course on diabetes. And I thank the API President, Dr. Jyotirmay Paul, Dr. Kamlesh Tiwari, Dean ICP, then Dr. Girish Mathur, Dean-elect ICP, and the entire team of ICP, Dr. Sanjay Kumar, Anand Jha, and who are managing this. And I hope the program is running well and all the participants are getting benefited because of this. And as told earlier, that we have to be in this program and have to attend at almost 80% of the modules, and then we have an exit exam at the last. So I would request all the participants to be there and clear the exam and get the certificate. So up till now, we have discussed about the introduction of diabetes and then the pathophysiology and then classification of diabetes. So now we come to the evaluation of patient with diabetes, and how to evaluate a patient who presents to you with the diabetes. So we all know about type 2 diabetes. Now we have discussed the classification and definitions. That's the most common form of diabetes, and the prevalence is increasing rapidly, especially in the developing countries. and it occurs due to relative insulin deficiency in an individual with insulin resistance, and it's usually asymptomatic and detected during evaluation for unrelated indications. Now, this point is important. This usually asymptomatic and detected during evaluation for unrelated indications, and we all know that there is a large number of patients who are pre-diabetics or those who are undiagnosed for quite a period of time, and they present with complications sometimes, and they uh, may present with hyperglycemic symptoms, which are classical, where you have polyuria, polydipsia, and polyphagia along with weight loss and other complications. So whenever you evaluate the patient, the history is perhaps one of the most important thing, and you have to ask for symptoms of diabetes, where frequent urination, excessive thirst, excessive hunger, weight loss, delayed healing of wounds, tiredness, itching especially in the genital areas, tingling and numbness, and visual disturbances. So you may have any of the combination of the above said symptoms, or maybe the patient may be asymptomatic. As you can see, that 60% of the patients may be asymptomatic. So medical history, you also need to know about the previous treatments and outcomes, present treatment, drug allergy, any intolerance to any of the drugs, history of hospitalization in the past for whatever reason it is, whether the surgical reasons or the medical reasons, then history of any hypoglycemia or DKA, or the hyperosmolar state, the acute coronary event, and the cerebrovascular events, or any other infective causes or infections like pneumonia or wound infections or UTIs. So this will give you the full insight into the patient's medical history and record, and ask for symptoms suggestive of complications also, because sometimes what happens is the patients, they present very late and they are already having complications, and facial puffiness, pedal edema, nocturia, angina, effort intolerance, claudication, sensory impairment, pain, gait disturbance in the dark, and sexual dysfunction. The last one, which I mentioned, is very subtle and is not being complained of by either of the sexes. So we have to elicit that history. And sometimes the sensory impairment or maybe the gait impairment may also be missed, because the symptoms and the signs, they are so subtle, or they are not being observed properly by the patient. So we have to elicit the history of all these. So let's just see a case over here where Mr. He is a 46-year-old man who is newly diagnosed with type 2 diabetes, and this is his first visit to the hospital. And his height is 168, weight is 74, and BMI comes to 26, which is just above the normal range. And blood pressure is 140 by 80 in the supine posture and 150 by 80 in the erect posture. So, what additional signs you should routinely look for in a patient with diabetes? Anybody wants to say what additional signs you should routinely look for a patient with? Okay, let's see the signs. Basically, it comes to the physical examination of the patient, and besides the height, weight, BMI, and waist circumference, we all know that the waist circumference is an individual risk factor. So we should not be left only with BMI, but we should be measuring waist circumference, hip circumference, and waist hip ratio. So the biometrics basically of the patient is very important, and you need to know about the blood pressure, which is the most common associated comorbidity with diabetes, including the postural variation if there are any symptoms suggestive of that. And in that case, you need to measure both lying and standing, or sitting and standing blood pressure. Examination of abdomen, then thyroid examination. The patients, they have concomitant endocrinal problems, and thyroid problems being one of the most common ones. So thyroid examination is important. Skin examination for markers of insulin resistance like Acanthosis nigricans, especially in the females who suffer from the polycystic ovarian syndrome. The skin tags, and if somebody is on insulin, then insulin injection site inspection is also very important. You need to whether the skin is getting damaged or if there is a localized lipoatrophy or any other problem. If somebody is bleeding from the site of insulin injection, then there is a problem of insulin injection technique. Besides that, later on we will learn in our modules that how these skin problems they come up in diabetics and why skin examination is so important, because there are plethora of skin problems which are associated with diabetes. Then you have dilated retinal fundus, retinal examination, and it's very important because if you can catch retinopathy in early in the stage, then probably you can do something about it and you can guide the patient and tell him that he is going to have major problems in future. So whether it's the non-proliferative retinopathy or proliferative retinopathy, we need to know when we examine the patient for the very first time and then periodically as and when need arises. So, dental and oral examination is important. Again, a missed part, and normally the physicians, diabetologists, and endocrinologists they will miss it and they will refer the patient to a dentist. Whereas a preliminary examination of not only dentition but the oral hygiene, especially those who are tobacco chewers, so we can have clue of the basically mucosal health. And the tongue, the mucosa speaks a lot about the general condition of the body, so it's an important aspect. And you can see the footnote that the waist circumference needs to be measured at the midpoint between the costal margin and the highest point of the iliac crest, with the breath held in expiration, not in inspiration, but held in expiration. So, comprehensive foot examination is very important because diabetic foot is a major problem, and when it happens in any diabetic, then it becomes a almost a untreatable like situation, or it takes a long time to treat, whether it's diabetic foot ulcer or infection, or maybe somebody who already has suffered the amputation because of either neuropathy or the vasculopathy where peripheral arterial disease plays a problem. So inspection of the foot, so what is the arc of the foot, whether there are any callosities, whether there are any deformities, how is the skin basically, if there are any scar marks or there are cracks or fissures in the soles, or whether there is an intervertigo in between the toes, the nails. So whether they are any ingrowing nails, so that can also be a big problem in diabetic. So palpation of dorsalis pedis and posterior tibial pulses to know about the circulation, the ankle brachial index, which again is an indicator of peripheral arterial disease and can indicate you to the other problems like the, even the coronary artery disease or any vascular disease in any other part of the body. Then knowing about the ankle and the knee jerks, which will tell you about the neuropathy if there is any. And then finally, proprioception, vibration, and monofilament sensation is important and can be tested very much with minimal equipments in the clinic on the first visit and then periodically to tell you about any involvement of the nervous system if it is happening. So this we all know. This is a very basic examination, elicitation of ankle jerk and vibration sense by an 128 hertz tuning fork. So, but normally, uh, yeah, if the consultants they are in hurry sometimes or they don't pay attention to this, and please note that these complications they can be present for the very first time when the type 2 diabetes or even a type 1 diabetes presents to you in the clinic. And normally we think that the neuropathy and the retinopathy or nephropathy will take time to develop over the period of years. And so we sometimes tend to ignore this part of examination, but it is very much required right from the beginning. So this is the monofilament test. The James Winston monofilament test is a simple screening test for diagnosing patients at risk of ulcers due to peripheral sensory neuropathy. And we all can do it. And The only thing is that the inertia of not doing it should be removed. Then, once you have taken the detailed history of the patient and you examined the patient, and here I would like to mention that the systemic examination is also important. So, examination of the cardiovascular system and the respiratory system is sometimes important, and you should look out for the subtle neurological changes also which can come in. So, like somebody is having a sixth nerve or a third nerve involvement, which can sometimes come in diabetes. So that part should also be looked for at least when you are examining the patient for the first time, or if somebody is putting a complaint, or maybe periodically at 1 year, or uh, uh, maybe later as the condition of the patient is. So once you are through with the history and examination, then comes the turn of the lab investigations. And if you see the lab investigations in any patient with newly diagnosed type 2 diabetes, then fasting and postprandial plasma glucose, the HbA1c, the fasting lipid profile, the liver function test, the urine complete examination, including assessment of microalbuminuria, serum creatinine, and estimated EGFR. Now, this is important, estimated GFR. We all do serum creatinine, but as we all know that the classification of the chronic kidney disease is based on the KDIGO guideline, which takes into account the EGFR, and the EGFR decline comes in much earlier before the levels of the creatinine goes up. So the measuring of serum creatinine may not give you the true picture of decline in the kidney functions, and estimated GFR is important. Many of the labs have started doing this test, but we can calculate it by using a formula also, which is quite handy and is available on net also. But we should be asking for doing estimated EGFR. Then hemogram is important because the to assess the comorbidities, and diabetes in itself can lead to some hematological problems. And finally, ECG, chest X-ray to know about the cardiac status, then echocardiogram, then maybe thyroid functions. You can do it selectively, select in selected cases, but in majority of type 2 diabetes, at least during the first screen, we should be doing all these tests. So if you talk about test of glycemic control, then plasma glucose, whole blood glucose in case of glucometers you are doing, then HbA1c. And if the patient, if you feel that there is problem in managing the diabetes, or if somebody is having brittle diabetes, or if somebody is having hypos and hyperglycemia, then probably continuous glucose monitoring and measuring the glycemic variability becomes important. So these are the parameters which are used for glycemic control. So plasma glucose, both in fasting state or maybe postprandial or random blood glucose, then whole blood glucose, they the glucometers should be calibrated, and then glycated hemoglobin. Uh, Please note that the different labs or the basic labs, they've been using glycated hemoglobin term for HbA1c or the total glycated hemoglobin. We should be knowing that there is the difference between the two, the glycated hemoglobin and HbA1c. So we should be going for HbA1c test. And finally, CGMs. Now there are basically uh, advanced CGMs which are available and very comfortable also. If somebody can afford, or if there is a need, then we should not hesitate to use CGM also. So, talking about the plasma glucose measurement, the methods are oxidation reduction methods, the enzymatic methods, where the glucose oxidase and hexokinase methods are being used, and enzymatic methods are the best method. And out of that, the glucose oxidase method is the standard and is being used maximally. If you talk about the glucose meters, then they check the capillary blood glucose, where the laboratories, they report on the venous plasma glucose, because we take out the venous blood, and the plasma glucose values are 10 to 20% higher than the whole blood glucose values. And the most modern glucose meters report result as plasma equivalents these days, thereby obviating this problem. So they compute basically and correct themselves, and they give you a result which is plasma equivalent. However, the differences between the venous and capillary glucose levels persist while using glucometer, particularly after meals. So what we will find sometimes is that when the patient comes to you, he will give you a report of his self-monitored blood glucose report in fasting stage, which matches the lab report. But there is often a discrepancy in the postprandial values because the accuracy of the glucose meters, it changes in the postprandial state. And whereas the lab will give you a lesser value, most of the time the glucose meters will give you a higher value. So that is the problem in assessing the postprandial blood glucose with glucometers. The differences are or can be up to the tune of 20%, and capillary is higher than venous blood glucose in the postprandial state. And if you talk about the arterial versus capillary versus venous blood glucose after 100 gram glucose load, you can see the graph shown over here. The arterial and the capillary glucose, the graph is much higher, all the values, and as compared to the venous. And the definitions which we use, or the cutoffs which we use for diabetes, are basically based on the venous blood glucose rather than the arterial or the capillary blood glucose. Coming to urine glucose testing, it doesn't have too much of significance nowadays, and it was an old technique where the blood glucose testing was not readily available. And advantages were that it was cheap, convenient, easily available, but it's no longer a standard treatment and can be used in only in certain situations because of their its obvious disadvantages, like it's a semi-quantitative test and does not differentiate between marginally and profoundly elevated blood glucose levels. And also, if somebody is having a borderline increase in blood glucose, then the glucose won't show up in urine and the urine glucose testing will be of no use. So, and again, it's not a real time. It only indicates the blood glucose level since the time of last voiding, and it does not differentiate between normo and hypoglycemia. It's not useful in pregnancy because the threshold in the pregnancy goes low. And what happens sometimes or many a times is that we get references for pregnant females where the urine is showing blood glucose. But please note that there is a lower renal threshold as compared to a normal person. And then again, nowadays, with drugs like SGLT2 inhibitors, which causes glycosuria as their normal mechanism of action. So, by and large, the urine glucose testing is obsolete and is of no use until unless you don't have a facility to check blood glucose. That's a separate story. So, coming to a case study, uh, just see a glucose tolerant test for diagnosis. So, plasma glucose at 0 minute is 78 and 128 minute is 84, and urine glucose is still 2 plus. So despite having normal blood glucose levels, urine is showing the urine glucose. So this can happen in, and again, happen in renal glycosuria, or maybe if somebody nowadays, somebody who is on SGLT2 inhibitor. So this kind of situation can be seen in the those patients. Another case where the plasma glucose is 200 and in the postprandial is 290, but still urine is not showing any glucose. So what can be the diagnosis? It's the other side of renal glycosuria, you can say, or why the urine is not showing up, because we all know that the normal threshold cutoff value is 180, and if the blood glucose goes above that, then you will have urine glucose showing up in the urine. Any clue anybody wants to say? Now, what happens is that in the type 2 diabetes, sometimes the renal threshold goes up from the normal. For a normal person, the renal threshold is 180. For pregnant females, yes, we saw that the renal threshold goes down. But in sometimes in the long term, in type 2 diabetic, the renal threshold goes up and there is an increased renal reabsorption of the glucose, and it is not being filtered in the urine. So that these is the subset of the patients where probably the drugs like SGLT2 inhibitors will have maximum action, because they will address the problem of increased renal reabsorption of glucose in type 2 diabetics. So glycosylated hemoglobin and HbA1c should be knowing very. This is a standard term nowadays, and not only the doctors but the patients are also aware, and they will come with their reports of HbA1c. But please note that the term glycated hemoglobin refers to a hemoglobin molecule that has been modified by non-enzymatic addition or glycation, you can say, of a glucose moiety. And the term HbA1c specifically refers to hemoglobin molecule that has been modified by the non-enzymatic or addition glycation of a glucose moiety to the N terminal of its beta chain. So there can be a HbA1a, HbA1b, then you have an HbA1c. But then if HbA1c is the major component and constitutes most of the part of the glycated hemoglobin, so it is almost synonymous and is the real indicator because the binding of the N terminal is most specific and long lasting. That's why we assess HbA1c, and normally there is a gap of almost 1% between the total glycosylated hemoglobin and HbA1c. The previous kits used to assess the glycosylated or you can say glycated hemoglobin GHB, but nowadays we are assessing HbA1c. And we all know that HbA1c level will reflect the glycemic control over the duration of lifespan of RBC, that is around 120 days, because this binding or glycation of N terminal of the beta chain of hemoglobin is irreversible. So it goes away with the death or senescence of RBC. Now hemoglobin A, then hemoglobin F, and then you have some other hemoglobins. So when you have the non-enzymatic glycation at the lysine and the valine residues of hemoglobin A, then you have HbA0, HbA1a, HbA1b, and HbA1c, and you can see that 80% of total glycated hemoglobin is HbA1c. So that is why there is a gap of almost 1% between the assessment of total glycated hemoglobin and HbA1c. If you see about the clinical value of HbA1c, it's an index of long-term glucose control, and it's performed on venous blood. And test results are not affected by the time of the day, meal intake, size, or any recent or just administered diabetic drugs, emotional stress, or patient cooperation, which normally can give a fluctuation in the random blood glucose or fasting blood glucose at that point of time. But HbA1c does not change with these values, and that is the advantage, and that is why it is being used as the marker for long-term glycemic control. So it helps in clarifying the discrepancies between self-monitored blood glucose levels and the actual degree of overall blood glucose control. And it's helpful in differentiating stress-induced transient glucose intolerance from true diabetes, just like any hospitalized patient who will show up with high blood glucose, like cardiac patients or anybody who is having acute infection or in ICUs, where you'll find that the casual plasma glucose values are higher, but if you see the HbA1c, then that's normal, which indicates that's stress-induced hyperglycemia and it's momentary. It's useful in clinical decision making, that is choosing and upgrading therapy, because the complications, the various trials up till now have seen that the complications of diabetes are related with the overall glycemic control of the patient over the long period of time. And for that, HbA1c is the best marker, and we all know that we have to keep it uh, between 6.5 to 7 in almost all diabetic patients, barring few where there are compelling indications to keep it on the higher side. And it's useful in obstetric practice also because it's useful in predicting congenital anomalies in newly pregnant diabetic females. And now it is used as a tool for diagnosis of diabetes as well, where it is pitched along with fasting blood glucose and the postprandial casual glucose as one of the definition criteria for diagnosing diabetes. So methods of estimation, methods based on charge differences where ion exchange chromatography, the HPLC and the Agar gel electrophoresis, and then you have methods based on structural differences, boronate affinity chromatography and immunoassay using monoclonal antibodies. And you can see that the few tests will measure the HbA1c and few will measure the total glycated hemoglobin or both. And HPLC is the gold standard test and it will give you the correct values for both glycated hemoglobin and HbA1c. But there are conditions which can cause falsely high and low HbA1c values, which we should be aware of. Otherwise, it can lead you into a problem regarding decision of therapy for that patient. And there are conditions which can lead to inappropriately low HbA1c, like hemolysis. If their RBCs are dying prematurely, then certain hemoglobinopathies, any recent blood transfusion, because it will change the RBC mass basically that is circulating in that patient, acute blood loss, then hypertriglyceridemia, which helps in or interferes in the assessment of HbA1c. Then there are a few drugs, then chronic liver disease. Then there are conditions on the other hand which can lead to inappropriately high HbA1c like iron deficiency, vitamin B12 deficiency, alcoholism, uremia, hyperbilirubinemia, and then again there are drugs and variable effect on HbA1c can be seen because of the presence of fetal hemoglobin, methemoglobinuria, and certain hemoglobinopathies which lead to erratic binding of the glucose moiety to the hemoglobin A chain. So coming to the drugs, uh, which can affect HbA1c levels, then there are various postulated mechanisms how these drugs interfere. So if you see about the increased erythrocytic destruction, then falsely low HbA1c can be because of use of dapsone, ribavirin, all antiretrovirals, cotrimoxazole, and hydroxyurea. And altered glycation can be present because of vitamin C, vitamin E, and aspirin in small doses. Now, please note that aspirin runs in large number of diabetic patients, and this small dose of aspirin can interfere with the assessment of HbA1c, and you can have a falsely low HbA1c in these patients. So we should always be careful about that. Then aspirin in large doses can also have interference in assaying, and again the chronic opiate use can lead to falsely high HbA1c because of the same interference in the assaying. So, in patients who have been recently initiated on anti-diabetic drug therapy, the HbA1c may be inappropriately high for the degree of hypoglycemia. So, that is true because as soon as you start the therapy, the fasting blood glucose or the postprandial or casual plus blood glucose they start falling, but HbA1c will take time to fall. So be cautious about that. So don't have any judgment on HbA1c before the designated time for it to change, and that would be at least 1.5 to 2 months where it will show change, and optimum time would be 3 months. So HbA1c targets in patients with diabetes. There are different associations globally who recommend the different cutoffs, and you can see the American Diabetes Association, which is the largest body of uh, diabetic professionals across the globe, indicate has given a cutoff of less than 7, whereas IDF, that is International Diabetes Federation, recommends less than 6.5. Then ACE recommends less than 6.5. That means they both recommend more stringent blood glucose control as compared to ADA, and our own RSSDI, which again says less than 7. However, it is very important that the targets for blood glucose control needs to be individualized, and normal values in non-diabetic population are not well defined. But anybody who is having a HbA1c between 5.7 to 6.5 is labeled as pre-diabetic, where 6.5 and above is labeled as frank diabetes. So HbA1c can be used as a diagnostic test for diabetes, providing that the stringent quality assurance tests are in place and assays are standardized to the criteria aligned to the international reference values, and there are no conditions present which precludes its accurate measurement. And we have seen the conditions which can give you falsely low or falsely high HbA1c. Initially, these tests were costly, but now with the rampant usage, wider usage of this test, the costs have also come down, and it is recommended that we should be ordering this test routinely to all diabetic patients as per the recommendations and individualized need. So coming to another assay is the C-peptide assay. So C-peptide, its name is connecting peptide, is a polypeptide consisting of 31 amino acids, and it's called because it connects the A and the B chain of the insulin in the proinsulin molecule. So it is a byproduct of insulin biosynthesis, and for every molecule of insulin secreted in the blood, there is one molecule of C-peptide. So that means it's a equimolar secretion, and if you can detect the C-peptide or assess the C-peptide level, then probably you can assess the amount of insulin which is secreted in the blood. Why we don't go for directly measurement of insulin? Because it is shorter acting and it is difficult to assay basically and the levels. So that is why it is convenient to measure C-peptide, and it basically can serve as a marker of pancreatic beta cell function. So this is the C-peptide. You can see the A chain and the B chain of the insulin, and then you have the connecting peptide in between, which is uh, in the human proinsulin molecule, and that is the C-peptide. And when it is being released, the A chains and B chains, then the C-peptide gets released from that proinsulin molecule. Coming to the interpretation of the result, the normal values, they may vary from lab to lab based on the kit or condition in which the test is being performed, whether it is the fasting or stimulated with glucagon or a standard meal. And greater than normal values may be seen in the pre-diabetic stage, where there is a stage of insulin resistance or maybe in insulinoma. And then lower than normal values comes when the insulin secretion falls below a critical level, and the insulin requirement requiring diabetes, whether it's type 1 or type 2, you will have the type 1 will have obviously almost negligible or zero c-peptide levels, and the insulin requiring type 2 diabetes will show a decline in c-peptide. Then you have the pancreatic diabetes, there you will have a decrease in c-peptide, and the monogenic diabetes, MODY, you will again have, and very lower absent obviously will come in type 1 and post total pancreatectomy patients. But it is important to note that c-peptide values should always be interpreted in the light of plasma glucose levels, and it is advised that when we order for this test, it should be coupled with the fasting plasma glucose levels, or maybe the postprandial if it is done in the postprandial state. So it is a differential diagnosis between type 1 and type 2 diabetes. That is most common usage of C-peptide, and it can differentiate between type 2 and LADA also. And because this is very difficult to diagnose, differentiate between LADA and type 2 diabetes sometimes. So C-peptide comes in handy. And then finally, in type 2 diabetes, it can help to decide the therapy, because it can indicate the falling insulin secretion level, those who are on secretagogues like sulfonylurea, and can indicate about the secondary sulfonylurea failure. Although C-peptide is a useful tool, it is not an essential investigation either in the diagnosis or management of diabetes. If you see for investigations for diabetes complications, then detection of diabetic kidney disease is important, and this is the test: microalbuminuria, which is perhaps the earliest detectable stage of diabetic kidney disease. It's a marker of generalized endothelial dysfunction and a predictor of cardiovascular disease in future. So measuring this is or estimating microalbumin levels is very important. It refers to a level of urinary albumin excretion that is higher than normal but below the threshold of detection by conventional methods. And kidney disease is reversible if treated at this stage of microalbuminuria. So, test for presence of microalbuminuria annually in all patients with type 2 diabetes, starting at the diagnosis, but in type 1 diabetes of more than 5 years duration, you have to test it annually. And method is that measurement of albumin is to creatinine ratio in a random spot collection of urine and 24-hour collection with creatinine, allowing the simultaneous measurement of creatinine. Urine dipsticks for microalbuminuria semi-quantitative are useful. So these are the definitions of microalbuminuria. You can see that in the normal albuminuria, the 24-hour collection will show less than 30 milligram percent. In the microalbuminuria, between 30 to 299, and macroalbuminuria, or you can say the frank albuminuria, is more than 300. And if you see the albumin creatinine ratio in the random spot sample, then it is less than 30, and again it is 30 to 299 is microalbuminuria, and macroalbuminuria is more than 300. ADA has recommended the use of terms normal urine albumin excretion, that is UAE, and abnormal UAE as opposed to microalbuminuria and proteinuria. However, still the conventional terms microalbuminuria and macroalbuminuria are being used, but we should be using UAE and abnormal UAE. If you see for diabetic retinopathy in the type 1 diabetes, the retinal examination should be done within 5 years after the diagnosis and every 1 to 2 years thereafter. But if you see type 2 diabetes, then retinal examination should be done at the time of diagnosis and yearly thereafter, or as the need may be if somebody is having florid retinopathy. Coming to the evaluation of feet, then this is the instrument which you can see is a biothesiometer, and it is checking the vibration perception threshold. Then this is the Doppler ankle brachial index. Then if you see the definition of peripheral vascular disease based on ankle brachial index, then the peripheral Doppler probe is used to detect the pulses, and the ankle brachial pressure index can be calculated using that, and PVD or peripheral vascular disease diagnosed if the AVI is less than zero point 0.9. If it is more than 1.1, it's okay, and if it is between that, then it's a borderline AVI. Coming to the CGM, you can see that there is a device. This is a meter basically for CGM. So the components for CGM are the sensor, a reader, and a software for analyzing the patient data. And on the left hand side, you can see how the sensor has been applied to the forearm of the patient. And on the right hand side, you can see the reader. So reader nowadays are very good, and they can, if you just scan the reader above the sensor, it will give you the blood glucose value at that point of time. It's not a blood glucose; it's an interstitial fluid blood glucose value, and then there is a software which will analyze the recordings which have been done in this sensor for whatever time it has been applied. So maybe it's 7 days or 14 days. So earlier sensors, they used to require frequent calibration with capillary glucose estimation, and they measured glucose levels only over 5 to 7 days. But now they can measure up to 14 days, and the advanced ones, they can go do it further. And the latest continuous ambulatory glucose monitor system utilize pre-calibrated sensors, avoiding the need for frequent finger prick. They can work up for 14 days normally, but the newer ones which will come will have extended period of time. And sensor insertion is virtually painless, and sensor is unobtrusive to the acts of daily living. And the software collapses all glucose readings from several days or weeks as if they occurred in a single 24-hour period, making it easier to visualize glycemic patterns. And you can see the graph over which has been created by the software, where you can see the variation basically of uh, in 24 hours over the period of time where the blood how the blood glucose has fluctuated, and you can have a mean basically and the median uh, for that period of time, that is the 14 days. So on the top, you can see the normal glucose profile, low variability in all values within the target. But when you see, and the estimated HbA1c in the above graph is 5.2. Whereas if there is a patient with well-controlled diabetes but high glycemic variability, you can see the graph on the bottom, and you will find that this patient is having fluctuating blood glucose, where one reading is showing, as shown in the red box, as 55, and then there is hypoglycemia and hyperglycemia both happening in this patient. So that is the advantage. Both the patients' profiles have the same HbA1c of 5.2, but on the top there is no evidence of hypoglycemia. But in the bottom graph, you have incidences of hypoglycemia and hyperglycemia, which although is giving the same average of HbA1c of 5.2, but is deleterious for the patient. So a patient with diabetes with poor glucose control and high glycemic variability, you can see the such haphazard graphs on the top. HbA1c is 7.9. So the overall glycemic control is poor, and the variability is also very high. So the concept of time in range, which is an important metric measured by modern CGM systems nowadays, and based on that, there have been recommendations that the time in range refers to how much time the patient spends within a pre-specified target blood glucose range during the period of recording. And normally, type 2 diabetes, they should remain between 70 milligram to 180 milligram percent for majority of that time. So that is the target range, 70 to 180, and then 180 to 250 is high, and above than 250 is very high, and below 70 is low, and below 54 is very low. So we should be avoiding the low, very low, and the high and very high categories, and we would like our patients to be passing maximum of time in target range, that is 70 to 180 milligram percent. So these are the consensus guidelines for time in range, and you can see type 1 and type 2 diabetes. The recommendation is that the patient should pass more than 70% time in with target range, that is 70 to 180, with less than 25% in more than 180, and less than 5% in 250, and almost less than 4% below 70 milligram percent. And if you talk about severe hypoglycemia, which is less than 54, then the time is should be less than 1%. And if you see the older or higher risk type 1 and type 2 diabetic patients, then the targets become lax, and you will like them to not have any hypoglycemia, or rather severe hypoglycemia. They can thrive on higher blood glucose values, where you will see that 50% patients have been recommended they can afford to have blood glucose of more than 180, but the hypo should be less than 1%. Come to the graph 3, where you have pregnancy with type 1 diabetes. The target range for time in range is more than 70%, and you cannot allow high blood glucose. But the target range for pregnancy is 63 to 140 milligram percent, as opposed to a normal person. And above 140 is high. So the allowance for more than 140 is less than 25% of the time in the day. And obviously, hypoglycemia is not recommended, but the cutoff for hypoglycemia is 63 in pregnancy, and severe cutoff for hypoglycemia is 54, same as a normal individual. So if you talk about the type 2 diabetes, then the target range is 60 to 140, and it is advisable that the maximum time, maybe 90% time, should pass in this range, and the hypoglycemia should not be more than 5%, and the hyperglycemia, which is the cutoff of 140 milligram percent, should not be allowed for maybe 5%. So we come to another case study where there is a female who has been diagnosed with type 2 diabetes 6 months ago and has been started on oral anti-diabetic agents. She has come for the 6th month checkup. And what are the laboratory investigations you do? So this is how the flow of investigations runs for these patients and how these patients should be monitored during their clinic visits. So in first visit, you have an HbA1c, glucose, lipid, LFT, RFT, the urine albumin creatinine ratio, UACR, or you can say UAE, the hemogram, the cardiac workup, the TSH, the retinal examination, the foot and dental oral examination, and probably the systemic examination. And then once in 3 months, you should be doing plasma glucose and HbA1c. And once in 6 months, you should be doing lipids also besides HbA1c and plasma glucose. And annually, the test needs to be similar to the first visit. And on top of that, screen for diabetic complications, because you may have new complications which have set in that 1 year period of time. And then finally, the investigation needs to be individualized and can be tested. Uh, Basically, you can have more battery of test or lesser test depending on how good the patient is controlled and what symptoms or complications he's coming with. So with that, we end our presentation over here. And if there are any questions, I think we can put it into the chat box, and we'll try to discuss that. Thank you very much. Thank you.
There are few questions in the chat box.
Okay, let me see that, sir, and then I'll come back. So there is a question about role of HbA1c in body, and obviously, but we have discussed that in any form of diabetes, the blood glucose control is important, and we need to know about the blood glucose control. And the HbA1c is the best parameter which can tell you about the glucose control, and HbA1c is handy in body also. I think that was the only question which I could see.
Someone wished to know about the accuracy of CGM.
CGM, yes, very good. So CGM is also quite accurate, and nowadays with the meters, they are calibrated, and they will. But the only problem with the CGM is that it is assessing the interstitial fluid. It is not assessing the venous blood glucose. One, and two, there is a lag between change in the values between the blood and the interstitium, because in the blood glucose, which changes rapidly, it will take some time to reflect in the interstitial fluid. So that is the only problem. But by and large, with the CGMs, they are very accurate, and they give you an insight about the glycemic variability, which is very much important, which you cannot judge by the fasting or the PP blood glucose or even HbA1c.
So very nice, sir. It was really a nice classroom learning. Since there is no other question, we may end the class here with, I would like to thank you and the participants for joining the class. So I hope they must be learning nicely about the topics, and really the evaluation of the patient in initial evaluation is very important, because because that permits us to treat or manage the patient in a better way. And not only the blood sugar measurement, but to look for the target organs also is very important, and it has been well dealt by Dr. Saxena. So many thanks to Dr. Saxena and the participants also. Thank you.
No, thank you very much, Dr. Sanjay, and I hope that the program runs well, and we will have the next class on next Monday
Yes,
at 3 p.m.
yes. So
Thank you
nice,
very much.
Thank
Thank you.
you.